Our next speaker is Dr. Dean Elterman. Dr. Elterman completed his medical degree followed by a residency in urologic surgery at the University of Toronto. He became a fellow of the Royal College of Physicians and Surgeons of Canada in 2011. He completed a 2-year fellowship in voiding dysfunction, neurourology, female urology, and pelvic reconstruction at Memorial Sloan Kettering Cancer Center and the New York Presbyterian Hospital Weill Cornell Medical College, in New York City. Dr. Elterman has worked in the areas of men's health and survivorship at the Iris Cantor Men's Health Center at New York Presbyterian Hospital Weill Cornell Medical College and at the University of Toronto. He's also the medical director of the Prostate Cancer Rehabilitation Clinic here at Princess Margaret Cancer Center, and he completed his master's degree in clinical epidemiology and health services research at Weill Cornell Graduate School of Medical Sciences. Dr. Elterman's clinical and research interests include male health, voiding dysfunction and reconstruction, including BPH, incontinence, and sexual dysfunction, as well as female voiding dysfunction, including overactive bladder and urinary incontinence. Ladies and gentlemen, Dr. Elterman.
Sorry, do you know what the name of the
second one?
This one? Here?
And so, what was interesting though was that he was getting married the next day on Saturday, and so all of his family, his extended family, his aunts, his cousins from overseas were all here in Toronto, and so this was a major setback. They were all ready to celebrate that weekend, and we didn't know what to do. Do we do the cancer surgery tonight and move the wedding? No, we can't do that. So we said, okay, go celebrate this weekend, have your wedding, and come back on Monday to have your testicle removed. So I couldn't imagine what that would be like to have a wedding, have your family here, and have sort of cancer on your mind. And so he did it, and I saw him on Monday, and we became very close, and we did his surgery, and he had a great weekend. He went away on honeymoon to the same place that I was on vacation in Europe. We saw each other there, and we kept in touch over the years. And then 3 years later, when I came back to Toronto General Hospital after being at Sunnybrook and other hospitals, my very first day, 8 a.m., my first surgery was for an RPLND, and it was him. And I was shocked, and he was shocked. But we saw each other, and we sort of had comfort in knowing that we knew each other, and we were going to be there for each other. And so it was really quite emotional for both of us. And so I did his surgery, and he's still my patient to this day. And he's on testosterone replacement therapy, which leads me right into what we're going to be talking about. So I'm here at the University Health Network. I work at all 3 sites, the Toronto Western Hospital, Princess Margaret Hospital, and the Toronto General. I'm here at the university, and I'm also a Mobro, and I think that also ties in very nicely with what we do. I've been a part of Movember for 8 years, 7-8 years, and so I think that's really important as someone who has a public image with our patients to not only talk the talk but walk the walk. So every year I wear a mustache for testicular cancer and prostate cancer, and I think that's something I'm really proud of. So I'm going to go over a little bit about testosterone, anecdotally a little about the history, some societal views about testosterone, and then more into the nitty-gritty about how we diagnose testosterone deficiency or low testosterone, some of the replacement options that may be available to you, and some of the side effects of being on testosterone. So this is kind of just more interesting. Testosterone replacement's been around for over 100 years. This very famous doctor actually injected himself with testicular extracts, and he felt rejuvenated physically, and mental abilities were heightened. And so that's kind of interesting. And then in the 1930s, they actually isolated testosterone from bull testicles and went on to have synthetic testosterone made, which is what we call anabolic steroids, in the 1930s, and that actually won a Nobel Prize. So when we think about testosterone generally, people think about bodybuilding, they think about competitive athletes, some of the controversies around testosterone, and so when you think about testosterone replacement, maybe there's a little bit of stigma. The first thing that comes to your mind is either illegal uses of testosterone, guys who are juicing in the gyms, Or maybe old men, and that's a large part of what I do is I see older men who have low testosterone, and certainly in this audience that doesn't necessarily apply, but the diagnosis, the treatment is the same as in your average population of men. So as men get older, their testicles make less hormone. Testosterone is made primarily in the testicles. And so we're seeing now, over about the last 10 years, an interest in the effects of low testosterone, certainly as men age. And so there's more drugs being prescribed, and the sense that as men get older or they have symptoms of low testosterone, that perhaps we should replace it to bring them up to normal levels. And of course that does apply to any young men who've had testicular cancer treatments, wanting to bring them up to normal levels. So this is an example here. This just shows an increase in the number of prescriptions in this graph in the United Kingdom, but it's doubled over the last decade. And I think this really speaks to our societal views of accepting testosterone as a valid form of medical therapy, and it's just becoming much more increasingly aware within the public domain. There's a lot of information and misinformation on the internet. There's websites that have experts about testosterone replacement. People have said that testosterone is going to be the fountain of youth and it's going to make you feel young forever. And I think there's a lot of good and bad information, so you need to be a little bit weary of what you read online. And certainly there's a lot of controversy about what is low testosterone. Are there values? Is it just a symptom complex? And when should you treat? So we'll talk a little bit about that. So what causes low testosterone, and who should be considered for testing? Again, this is just a very broad definition. We'll try and hone it in a little bit to this particular patient group. But we do know, as I alluded to, that testosterone declines over the decades. And interestingly though, there are men who are in their 40s, and I even see some men in their 30s who, without any previous cancer treatments, have low testosterone, and I replace their testosterone. So I guess another takeaway message would be, even though you've had, say, testicular cancer, you've had an orchidectomy, you've had chemotherapy, radiation, what have you, you're still a guy, and you may still have other things going on in your life, and you can't always ascribe every symptom you have to your previous cancer diagnosis. So it's important to stay connected to your doctors, be aware of your body, and also realize that things may be happening to you unrelated to your previous treatments. So you may just have low testosterone regardless, and that can be treated. There are a lot of other conditions that cause low testosterone. So people who chronically use opioids, narcotics, obesity. 52% of people who are obese have low testosterone. Diabetes also causes decreases in your testosterone levels. Other infections such as AIDS or HIV can reduce your testosterone. And other very common things in our population: high blood pressure, high cholesterol, and people with erectile dysfunction also have low testosterone. And so I think this gets to Nick's point about staying healthy. The best thing you can do before your surgery is be healthy. The best thing you can do, period, is stay healthy. Because if you can avoid obesity, diabetes, high blood pressure, hyperlipidemia, cholesterol, you're going to keep your testosterone levels as high or at least normal as possible. So who do we test for low T or low testosterone? We don't generally order it on a routine blood test in the family doctor's office. So we're not screening the whole population for low T. And it's really going on symptoms, and we have to do what we call objective and subjective testing. So subjective testing is how the patient feels. We ask them questions, we figure out if they have symptoms, and objective testing then would be the blood tests, for example. So on subjective testing, doctors will do both a history and a physical exam. We're looking at their overall health. We want to make sure that they don't have other medical conditions. We want to look at their blood pressure, their weight, whether or not they have diabetes, high cholesterol, and those are things that can cause low T as well. And we also want to screen for signs and symptoms of low T. We can give questionnaires which ask about your sexual health, your vigor or energy and other aspects of testosterone. And we're always going to be evaluating people for their other conditions and risk factors. So the indications for treatment, you have to have both. You have to have low testosterone on a blood test on 2 occasions, and you also have symptoms suggestive of testosterone deficiency syndrome, or TDS. The most important thing for me as a treating doctor is the symptoms. And we're going to talk a little bit about whether you measure total testosterone or free testosterone or bioavailable testosterone. But at the end of the day, if it's low, low-ish, normal low, but you feel really crummy, that's someone who I'm going to treat. There's no gold standard to the actual number. People get really fixated on the values. And you have to remember that these are averages. They've taken thousands of patients, thousands of healthy individuals in a population, and screened them, checked all their numbers, and they have a range of what's normal. But just because you're within a normal range doesn't mean you shouldn't be treated. And just because you have, say, a low testosterone, if you're asymptomatic, if you feel perfectly well, we don't have to treat you either. And that's for a lot of conditions. So don't get hung up on the numbers too much. So what are the signs and symptoms of low testosterone? They're actually not very specific, and it's quite broad. So looking here at the arrow from mild all the way down to severe testosterone deficiency, some of the earliest symptoms could be decreased libido, which is your decreased interest in sex, decreased vitality, decreased energy, you start to feel fatigue. Mood changes are very common, so depression, irritability, short tempers can be signs of both depression but also low testosterone. Insomnia, it disrupts your sleep, anemia, issues with sexual function and ejaculation, erectile dysfunction, and then when the degree of deficiency really starts to get pronounced, you start losing muscle mass, you start having abdominal visceral fat added on, your testicles can atrophy or shrink down in size, and really in severe, severe cases we're looking at weakness, changes to your bone health and strength, as well as loss of facial hair, other sorts of hair related to being a man. So there are also some confounding factors that may affect your testosterone readings. So the time of day is really important. Your testosterone levels go up and down over the course of the day, morning, night. You have normal internal hourglass. And so the morning is when your testosterone levels are typically highest, and that's when we want you to have your testosterone checked. You have to have an absence of illness or stress. So these other things can affect how the testosterone levels are read, and also the type of test that's done. So depending on the laboratory, they may test for different aspects of testosterone. They may have different normal values, and so these will also change how we interpret the findings of testosterone. So what about objective testing? These are things we can actually measure. So the serum, which is your blood, testosterone measurement, is done with symptoms. So if you, again, come in to see me and you feel like I'm really weak, I'm feeling crummy, my sex drive is low, I can't get an erection, I can't get out of bed, I'm feeling really depressed, then I would say, okay, let's check your testosterone levels in your blood. So the reason we check in the morning, again, is we want to give the best shot, the highest level. I don't want to check at your lowest, your worst. If you're truly low, I want to see that you're low at your best, if you can get that. So you're highest in the morning, so I want you to come into the lab and have your blood drawn between 7 and 11 a.m. is the best time. Now, this graph kind of shows the difference between total testosterone, free testosterone, and bioavailable testosterone. The details aren't so important, but it's just when you go into a lab or you go to your doctor, you get a report, they may have one value, there may be two values. One value may be normal, the other one is low. This is really confusing. You could come in and see me, and the total testosterone will be within the normal range, but say your free or bioavailable will be low. So what do we do then? It's a bit of a conundrum. For me, I would ask you how you feel. And if the numbers are low or low-ish, and you feel really crummy, we're going to replace your testosterone, if you want. So total testosterone is really easy to get. Most labs are able to do it. It's not the best test. It doesn't have a lot of accuracy, and there's other proteins in your blood that can alter it. The very best test is what's called the bioavailable testosterone. Of all the testosterone that you have, only a small fraction of it is active. The vast majority of testosterone is bound to proteins in your blood, and it's inactive. It can't activate any tissues. It doesn't do anything. It just floats around without any action. So it's the bioavailable testosterone which is actively circulating and can affect changes in, say, your muscles, your hormone receptors. That's what does the good stuff that testosterone does. There are different causes for low testosterone. Typically, when we're talking about testicular cancer patients, it's testicular origin. Low levels of testosterone, you get impaired production of sperm, and you can get elevated other hormones trying to stimulate testosterone production. There are other causes which are sort of higher up. If the signal from the brain isn't stimulating the testicles to make testosterone, then that's another form of having low T. So where does testosterone work? It kind of relates to all those symptoms that we discussed. It works on the brain. It's very important. It is involved in your interest in sex, your mood, how well you can think and concentrate. It affects how your liver and kidneys work, as well as your bones in terms of growth. It affects your skin, your hair, whether or not you have lots of hair on your head or whether you're bald, your muscle mass, as well as your sexual organs, the ability to make sperm. Having a large prostate is directly related to having a lifetime of exposure to testosterone, and as well as your bone marrow. So these are all areas that testosterone can target. So which testosterone replacement should you use? There's a number of factors that guide that decision. So the first is safety and whether you can tolerate it. The second would be efficacy. How well does it work? Patient preference is very important. Some people like taking pills. Some people like rubbing on gels. Some people don't mind getting a shot every now and then. So patient preference is very important, and of course, cost is a factor. So there are lots of formulations for testosterone that are available. There are pills, which I'm going to go through all of these in detail. There's pills, there are injections into the muscle, there's a patch, there are solutions that you can roll on in your armpit, and there's also gels that you can rub onto your skin. There are a few contraindications or reasons that you cannot use testosterone. The first is that if you have active prostate or breast cancer. And the other is if your hematocrit, which is a measure of the thickness of your blood, your red blood cells, is very elevated. And we would check that to make sure that it's not too high. There are other relative contraindications, meaning that if you have these, you have to strongly consider whether or not to use testosterone. These aren't typically found in men who've had the age range who have testicular cancer. This is mostly in older men, so men who have enlarged prostates, men who have higher risk for developing prostate cancer in later years, congestive heart failure, heart attacks, sleep apnea. Those are some things. So here are the different formulations, the things you can choose from. So the pills, it's called andriol, and it has to be taken 3 times a day. So for some that's very convenient, for some people that would be very inconvenient. The thing with the pills, though, is that it's really poorly absorbed, and you need to have a very high-fat diet for the testosterone to be absorbed. So if you look at this graph, up here, these are people who took the pill. The high graph is those who had a fatty meal, and those who just took it, say, on an empty stomach or not a very fatty meal. So if you're not having fatty meals almost 3 times a day, you're going to get very little absorption of testosterone. So it's not a great drug in the oral form. So I never prescribe it. Injections. Some people like the injections. It works very well. So there's 2 formulations. There's one's called ethanate and one's called cypionate. They're relatively the same. One has a slightly longer duration. So in one, you're going to need to have injections around every 2 weeks. The other maybe every 4 weeks. But essentially, it's something that you continually have to come back to get injections. I teach my patients how to inject themselves, or their spouse, partner can put a needle in their backside every couple of weeks. So it's not a big deal. It's fairly inexpensive. The issue with these is that you have a lot of fluctuations or changes in the testosterone over those 2 or 4 weeks. What happens, and a lot of my young patients who say have had testicular cancer, they're on the injections, some of them really like it. Because in the first week or 2 weeks, they feel incredible. They go to the gym, they're like ripped, they're going out, they look great, they feel great, they have so much energy, and then you kind of start to crash in the second half because the levels, as you can see, you get sort of a spike and then it kind of decrescendos down over time, and then you know when you need to come back for your next injection. So again, cheap, works well, kind of convenient, you need to have a shot. It's not quite natural. So our body's rhythms of releasing testosterone are much more stable. And so the gels that I'll show you mimic our body's natural testosterone production. But this is a very good option for those who want it. So now there are some gels. It's convenient. You don't have to have an injection. You get what we call a steady state or a steady serum concentration. And there's flexible dosing. You can give 1 squirt of gel, 2 squirts of gel, whatever you need to adjust how much medication you're going to need delivered. The downside is you need to use it every day. You need to put quite a bit of cream on. A lot of guys don't like putting creams on their body. They sweat. They don't like the sort of maybe the smell. Their wives or girlfriends are using creams, but other people say, hey, it's really easy. I just rub it on and I go. Now there is the issue of transference. So one of the issues with putting creams or gels on your skin is that it could potentially rub off on, say, your partner. So that is one of the, or if you have little kids, for example. So the biggest thing we have to warn patients who are putting gels or creams on is you need to be conscientious of washing your hands after you rub it on. And you have to be careful of putting your kids or your partner, snuggling in the evening if it's on your body. So that's one of the issues with transference. But it gives you a really nice steady state. You see here you don't have those high peaks and troughs. It's really pretty stable over 90 days, 180 days. Over several months of taking it every day, you get really, really steady levels in your body. So you don't have those highs and lows that you do with the injections. There's another formulation called Axoron. It's a transdermal topical solution. Theoretically has a lower risk of transference because you put it on like a roll-on deodorant. It goes in your armpits. Again, you can adjust the dose. So you squirt a little bit in. It comes in a little cup. You rub it in your armpit. You can use it with deodorant or antiperspirant. It doesn't make a difference. The only thing is you can't share your deodorant with your wife or girlfriend because then you get transference. Some people do. So you need to be aware of that. And again, it gives a very steady level of testosterone. There is a patch. It was originally used as a scrotal patch. So you actually had to put this big Band-Aid on your scrotum. You don't have to do that anymore. You can put it anywhere on your body. It works really well, except it gives a skin rash in about 65% of people. So if you don't get the rash, hey, it's easy. But if you get the rash, it's terrible. So it's maybe worth a try. I don't give it to a lot of people, but some people like having just putting on a patch. The doses are adjustable, and they're variable in terms of the type of preparation. So is that something you could talk to your doctor about? There are some newer therapies. So andriol, which is the gel, is coming out in a slightly higher dose. It's available in the States. There's something called Fortessa, which you rub on your thighs. I don't know if that's a big difference, but it goes on your thighs. And then Nabeetoes coming out. It's in Europe, and it's an injection that lasts for 6 weeks. So it's like a slow-release formulation. So that might be something that could be a lot more convenient for people to take. So you have to be monitored. Remember we said that it can cause increased thickness to the red blood cells. So after about, I say 3 months, come back. I check your testosterone levels. as well as your blood levels. If you're a little bit older, say around 40 plus, we're going to be checking to make sure you don't have elevations in your PSA for prostate cancer. And we're really going to look for improvement in your symptoms. How are you feeling? What you can expect when you go on testosterone replacement is that within about 3 months, you're going to start to feel improvements in your libido, your emotional well-being, your energy, and your sexual performance. And by about 6 months, you'll have increased strength, bone mineral density, your cognition, your thoughts will be better, start losing some of that extra fat that you had because of low T. You'll have some improvements in your metabolic symptoms. This is actually really interesting. So people who have diabetes or pre-diabetes, if you put them on testosterone, it fixes a lot of those parameters. So their blood sugars are better, their cholesterol is better. And so in human and animal studies, they've actually shown that you can reverse a lot of the effects of diabetes or metabolic syndrome by giving testosterone replacement. There are some adverse events that I tell all the patients. So you can have increase in your acne or oily skin. You can get some breast tenderness or changes to your red blood cells. This isn't so applicable to our patient population here today, but you have to be watching for prostate cancer. You will have reduction in sperm production and fertility. So this is relevant. So if you have a low testosterone and you're young, testosterone is made in the testicles. If you give outside testosterone, your body's going to think, aha, I have enough. And so your own body's ability to make testosterone is going to be suppressed. You're going to stop making your own testosterone, or it's going to lessen. But that also means that your sperm production may lessen. So if you're young and you have low testosterone and you're thinking about fertility issues, going on testosterone replacement may not be the right answer for you. But we have alternatives. So if you have low testosterone and you're thinking about having kids, I had someone 2 days ago. You can do another medication such as clomiphene. So that's a different type of hormone. And what it does is it increases the hormone that increases testosterone. It increases LH. So what it does is it actually goes back a step and increases the thing that increases the thing you want. Okay? All right. So that's something you can do, and so that's something to keep in mind. So if you're young and you're thinking about fertility and having kids and you have low T, it's not as simple as going on testosterone replacement. Prostate cancer, I think this is something just to dispel some myths. So about 50 years ago, they thought that testosterone causes or worsens prostate cancer. That has essentially been dispelled. There's really no evidence that testosterone causes prostate cancer or makes it progress in people who don't have, say, metastatic cancer. And so I find it's quite safe to use in men who obviously don't have cancer, even in men who've already been treated for cancer. And I even put testosterone on some men who have very low risk prostate cancer who are on surveillance. So if you're thinking about replacing your testosterone, I would advise you not to necessarily worry about prostate cancer's increased risk. Your risk is just like any other guy walking down the street. Now there are some effects of having low testosterone. So if you do actually have symptomatic low testosterone, you have the side effects, those symptoms of metabolic or diabetes can be enhanced. Your symptoms of being depressed, your well-being isn't well managed. You can develop osteoporosis or brittle bones. Again, you can lose muscle mass. And it really affects your quality of life. And there have been some very large studies looking at men who have low testosterone compared to those who have normal. Those who have low have increased risks of dying prematurely. So testosterone may actually be protective and a good thing to have, at least in normal levels. So lastly, I think just bring it to quality of life. I think when you look back at that slide I showed with all the places in the body that testosterone affects, it really does impact your emotional well-being, your physical well-being, your mental well-being, your sexual function, how you engage with your partners, your friends, society. There's a socio-emotional functioning, and of course your energy. And so I think it's really important to have this in the back of your mind. And remember that it really can affect a lot of aspects of your life, and it's something to bring up with your doctor if you're feeling low in any of these domains. So with that, I will conclude, and I thank you for your attention.
So the same thing applies for questions. We have a little less time, but we're still happy to hear any questions you have. I also have one online, so I'll read that now.
Sure.
So this one, this is a little more general. Doesn't necessarily relate to the topic you just presented on, but you can answer it how you will. My husband's testicular tumor came back as 6 different types of cancer. Mixed germ cell with embryonal, seminoma, choriocarcinoma, yolk sac, teratoma. My question is, does this play a part on his overall outcome? We've been told it's an unusual case.
So I will defer to my oncology colleagues who are here, but I will tell you as a urologist that there are many different kinds of testicular cancer, and I think maybe some of our other speakers will touch upon it. And each different type of cancer has very different treatments and prognostic aspects. So whether you have seminoma or non-seminoma, choriocarcinoma, yolk sac, embryonal, all of these are can be very different and treated very differently. I think our next speaker will talk about that, but that is actually a very important thing to bring up, because if you have mixed types of tumors, that is an important feature in the type of treatment you will receive. More to come on that.
Any other questions at all from the audience? Yes?
How would somebody, as a patient, come to see you? Do I have to get a referral, or can I just contact your office
So,
for an assessment?
so anyone can contact my office. I'm happy to see anybody. The way it works in Canada to see a specialist is your family doctor needs to refer you. So typically, I'm approached all the time by patients who I see at prostate cancer survivorship, testicular cancer survivorship, and I just give them my email and I say, contact me if you want to see me, and then I just give you the instructions on, here's my fax number, just have your GP send me a fax, and I'll be happy to see you. Yeah.
Yes.
You may have mentioned it, I did suck out for a second, but are testicular cancer patients at a greater risk of low testosterone? I mean, just because you had a testicle removed, does that mean you're at greater risk? I mean, there's no, yeah.
So I was talking about this with Nick before. Whenever you remove one organ, over time, the other organ can start to compensate. So when you remove a testicle, a kidney, I don't know about lungs, but I mean, when you remove something, the other one over time will start to compensate. So people have one kidney, that one kidney gets bigger. People have one testicle, that one testicle can start to get bigger. It's called compensatory hypertrophy. It can grow. So no, not every person who has an orchidectomy for testicular cancer will need testosterone replacement. I think, though, it's just important for you to be aware of the signs and the symptoms of low T. The people who I put on TRT, testosterone replacement, who've had testicular cancer, those who've had, say, bilateral orchidectomies, so they've had 2 tumors, or one orchidectomy plus a partial on the other side. So I have a number of men who've had low T, but at the same time, those who've just had one testicle removed. So there's not a hard and fast rule about if you remove one testicle, your testosterone is going to reduce by 50%. But it's something that we as a population here today should be aware of. And if you have any of these signs and symptoms, you can get it checked out and have it replaced.
I know post undergoing testicular cancer, you're subject to a lot of follow-up and blood tests and stuff like that. I was wondering if it's a common practice to monitor testosterone levels post treatment for, or would it only be if you just start to complain of symptoms of low testosterone?
I think it's variable, depends on the practice. Nick, what do you do? Do you check for T? Not every single visit, but from time to time?
So we're similar to the PMH steroids protocol, and at least here in patients who are survivors of testicular cancer, we will check this.
Right. So about once a year, I think, is reasonable.
Yeah, the trouble is, though, that some of the evidence is that actually the testosterone decreases over time. And if you take long-term survivors of testis cancer who are actually at the cancer center in terms of follow-up, it's those ones that you actually reduce. Some of the Scandinavian studies have actually shown that in 10, 15, 20 years, they're at a higher risk of lower testosterone. So, we do it once a year, but it's something, because we tend to discharge after 5 years, for many good reasons. Something to be thought of in the long term.
Long-term survivorship, it may be an issue. Yeah.
Oh, okay, I guess that leads to another question. So if you stop surveying after 5 years or something, is there any way that a patient could, ask to have it done? I mean, I know it's not covered for the general population, but is it inherently expensive if they were to request that testosterone test be done, say 10 years down the road? Is that doable?
It's absolutely doable. I think the reason that patients are discharged from the survivorship clinics is you're being followed for recurrence of your cancer. So to be aware now in our setting that the issues of testosterone deficiency may happen much later in life, just like they do in later in life in your average man, then it's something to be aware of. And your family doctor can absolutely check your testosterone, and it's not a very expensive test.
Okay. Dr. Ruckman,
Thank
thanks
you.
so much.